organizers for asking me to be here. What's new in HIV in women? It's basically finally a talk about women. Let's start off with epidemiology, okay? What do we know about women? I don't know whether you're aware, but there is really a disproportionate HIV burden among young women. If you look at the, where's my cursor? If you look at the right side of this chart, okay, that's the global population. You can see that globally, women represent about 46% of infection, but in sub-Saharan Africa, women represent 56% of infection. That's not all. If you look at the global 15 to 24-year-olds infection rates, we have 11%. I need a cursor, okay? And if you look again in sub-Saharan Africa, you're looking at 17%, okay? Much higher proportions. If you look at the left side of the slide, you can see that again, new HIV infections rates are probably the same between men and women, but if the proportion is nearly 1 in 4, yeah, the cursor, 1 in 4 in 15 to 24-year-olds. So a huge burden in women. Thank you. Right, moving on to next. Okay, that's not all. If you look at the burden in females by sex and age group, it's, oh God, sorry. Here you can see there, it really starts at the age of 15. This is women and this is men, you're orange and yellow, and by the age of 30 to 34, there is nearly a third, 3 times more infection in your women compared to men. Sorry, this is too quick for me. And this is in South Africa, but if you look for Kenya, look at that. At the age of 20, they just go off with a bang. And, you know, just to give you an idea of what it is for women. Historically, if you look at the data, there's very little, whether you look at in high-income countries, because everything is there is a trend for men to be studied, and most of the data is then extrapolated to women. This could be possible because women are on contraception, women give birth, and they're excluded from studies. But if you look at inclusion data, you can see that we really haven't made a dent in the last sort of 12, 15 years. Unfortunately, there are new studies coming up, Grace, Waves, ARIA, which are looking at women specifically, and I'm going to discuss some of them. So if I ask you, how do I choose an optimal ART for HIV-positive women? There isn't the data. As I said, they're underrepresented, and it's difficult to determine outcomes compared to men. You'll ask me, why are men and women different? I do say yes. I've already given you some facts about their infection rates. Oh, sugar, sorry. But here we are. They're more likely to discontinue heart. We all know that. The response to heart may be compromised by side effects. We know that women have more severe side effects. And then added the burden of social and cultural issues for initiation, adherence, retention, and so on. So yes, women are different. Now, in addition to all these differences, if you look globally, there are interactions with hormones, steroid hormones, contraception. Women fall pregnant, women are not that, they're physiologically different, and so on and so forth. So, you know, just to highlight that there are differences. So let's look at some of the trials. The first one that came was Grace, lovely name for a trial. And it was basically a study evaluating sex-based differences in efficacy and safety of ART. And there was an overemphasis in this trial for participants to be women, and you can see that there was 67% here, and 84% of them were Black or Hispanics for a change. And when you look at the intent to treat analysis, women weren't really doing as good as men. But when you, sorry, this cursor is really doing its own. And when you, however, when you took away the women, took away virologic women from who had discontinued or withdrawn from treatment, you could see that the heart was as efficacious as men. So basically, it was the discontinuations of women who had withdrawn from the study that skewed the results. So therefore, what I'm trying to impress is the fact that women, we do need to pay special emphasis to keep women, whatever, either in a trial setting or in the clinical setting. Moving on to WAVES. WAVES was basically a double-blind, randomized controlled study where ECTF was compared with atazanavir, ritonavir, and Truvada, and basically it was a head-on-head study looking at PIs and integrases, all right? Women with HIV RNAs more than 500 were taken. They had no previous heart experience. Their eGFR was more than 70, and they were randomized in this group. And if you looked at and there was a difference. Basically, the ECTF was superior to atazanavir, ritonavir, and this was quite marked. If you look at this here, there was a difference of nearly 6%. And again, there was no significant changes in other outcome measures like spine, BMD, cholesterol, and so on, LDL ratios. However, as you can expect, there was slightly increase in the cholesterol level because of the Kobe effect and EVG, okay? Fewer discontinuations were seen, as you can see here, 7 here, 12 here, and it was the atazanavir arm that had more failures compared to the EVG, ECTF arm. So obviously, good enough for all of us. Moving on to the ARIA study, this was again an open label phase 3 trial, and this was, you can see people from practically the globe, all the continents were more or less involved, Asia, Southeast Asia, Russia, so you know, a good trial where again the same parameters was used, and in this study, where the women did become pregnant during this period, they've been recruited onto a pregnancy study which is ongoing. So direct comparison between dolutegravir and Kyvexa with a PI. So what did it show? Overall, significant response here, and it favored Dolly, and again, as you can see, very few discontinuations compared to the PI arm, and very few virological failures. Very impressive, and you can see atazanavir arm showed almost threefold failures, all right? This slide is basically here to show that whether your baseline RNA was less than 100,000 or more than 100,000, your response was more or less the same with Dolly. It didn't really make a difference. Side effects, saying that, I don't know how many of you are witnessing it, but we are, you know, everybody says dolutegravir has no side effects, but we are seeing some side effects in a number of people, but otherwise, in this trial data, not a lot of side effects. I want you to focus on this particular study because I think it's a sort of a landmark study in why it's different it's necessary to conduct studies in women, because this was a study of basically substituting, it was ECTF, and basically in this study, TDF was substituted by TAF. And you can see this, no change in men, oh sugar, sorry. You can see in men, nothing changed, but see here what's happened. Once you replace TDF by TAF, there was significant improvement in both other outcome measures, not just virological suppression, but less BMD changes, less decline in eGFR, and numerically greater decline in proteinuria. So if the study hadn't been done, we wouldn't have known that, would we? Just a thought. Promise, again, we are awaiting data. This is something that you probably will hear more about in the forthcoming meetings. Moving on to guidelines. Are there any specific guidelines pertaining to women? Not really. The WHO has taken a public health approach by saying first-line heart, they can have everything here in bold is you can have efavirenz, you can have tenofovir, 3TC, and it's interesting to see that even in the absence of data for dolutegravir use in pregnancy and breastfeeding, it does feature as an alternative in their approach. However, personally, I still continue to use a tripler because the APR registry has not really shown any increased signal in the pregnancies where we have used this drug. But as you all know, that DHS says that, or WHO said, it should only be used after 8 weeks, and that's, I think, more to do with the outdated teratogenicity effects. Okay, BEVA does give some explanations. There are guidelines, so this is just to highlight that you can look at them and see and be guided by them. Moving on to contraception. When we look at contraception, there are two people. There is the contraceptive, and then there is the woman. So the contraceptive is barriers. Okay, correct use of condom, we know can prevent both, but how many people use correct condoms? And again, diaphragms and cervical caps are not recommended for serodiscordant partners. There are a number of drug-drug interactions between heart and hormonal contraceptions, and we'll talk about that a little bit later. And we all know that they are metabolized in the liver, so anybody who's HIV infected and Hep C infected is a problem when you think about contraception. When I look for a contraceptive, I have to look at, obviously, other things. What's the HIV status of the partner, and all the other factors that are here, are enumerated here. What ARVs are compatible with contraception? Basically, most of the PIs, efavirenz, even the new EVG, will cause either a decrease or increase in the blood levels of estradiol, norgestimate, norethindrone, and either they'll decrease the contraceptive efficacy or they will increase your estrogen, making the patient at risk of thromboembolism. So therefore, there are significant interactions, and this is something, asking a woman before you start her on heart, are you contemplating having a baby, is probably the best way forward. The take-home message in this slide is no interactions with NRTIs. You can use any contraceptive that you want, but all the black here is PIs. There are interactions. You may need a treatment change, or you may need to monitor the patient. So the worst here is atazanavir and efavirenz. These are the two drugs. When you're considering contraception, you need to be aware that there are potential interactions here. Moving on to impact, what has been the impact of scaling up? We've been all talking about scaling up for years. It's worked very well. We moved on from 2.2 million to nearly 15 million, and we've done really well. And the new recommendations are that regardless of CD4 counts, we should start everyone on heart. And that has happened, and this, I think, is a fantastic picture showing the dark green is where that has been done, and hopefully this will change over the next year or so, because it's just been implemented in Africa, okay? But this is more heartening, because in June, this is how the global adoption of option B in all HIV-infected pregnant women was seen, and that means that everything looks hunky-dory. This rapid increase in heart coverage during pregnancy with option B in Malawi, you can see that nearly 19% plus there was heart coverage in in their visit. So, very impressive. But I think we probably need to take home this message, is that women who were initiated on heart during pregnancy were more likely to have no follow-up visit and more likely to be lost to follow-up during the first 2 years compared to women who were started on heart if they were ill. So basically, women took the drugs when they had a baby, they had a child, they knew they wanted an uninfected baby, but once they delivered the baby, that was it. They weren't bothered about this. This is something I want you to take home with you. HIV testing and STIs, it's a care continuum. We screen people, if we find they are positive, we initiate a heart, and then we want an undetectable viral load. That's what the pundits tell me. But take Swaziland, okay? Interesting. Look at this. More women get tested, more women get diagnosed, more women are on heart, and more women are virally suppressed. That's brilliant, isn't it? But there is a problem. Men delay diagnosis and treatment and often have HIV RNA. So it's not really the woman who is important here, okay? Again, STI prevalence among young women in sub-Saharan African trials is horrendous. I mean, if you look at chlamydia, 12 to 14%, gonorrhea, TB, syphilis, it's there. Oh, sorry. I think what's important here, the HIV incidence across these placebo arms, that every 4 women out of 100 would, at the beginning of the year and till the end of the year, you'd have 4 to 9 women diagnosed with HIV in this study. And why is it important? I think this is the Bollywood love triangle. Men here have sex with women of the same age, but they also have sex with women younger than 25. So this is phylogenetic study which showed that 39% of men linked to a woman aged younger than 25 years or also linked to a woman aged between 25 to 40 years. So I don't want the men to take offense here because I think there are a lot more men here than women. PrEP in women. What is the evidence? We do know. Have we thought of adolescent women, requiring PrEP, and is it time to look at them as a priority? Okay. Early sexual debut, less than 15. Pregnancy doubles the risk. HSV2 especially is more common in women, and the risk is threefold. Sexual coercion is common. I don't need to tell this audience that. But this is incredible. Look at that. If a woman has only one sexual partner, she still has an increased risk of developing HIV 4 times more than a man. What the hell is going on here? Anyway, does it work in women? Yes, okay. There is data to show that it does work. 45% of participants were women, so in this partner it worked, in TDF2 it worked, and in voice there was a 47% reduction in women, so we know it's effective. There are ongoing studies where oral PrEP is being used, and we'll have more data on that, but there is also injectable PrEP studies which are being conducted in women and in transgender women, where rilpivirine as an injection is being used and cabotegravir is being used with tenofovir, and this we await the results of these studies. The other thing that we have, and which is probably something which is an add-on rather than just the only thing, is a deperverine vaginal ring. And basically, these women, they come to the clinic, a vaginal ring is put in their vaginas, obviously, which contains an NNRTI, and this study showed that there was a 27% reduction of HIV in these women. Again, the more you use it, the better you're protected. So the way they assessed it is they took the ring out and they looked for the amount of drug, and the lower level of residual deperverine meant that the woman had been adherent to the ring. And this is, I don't need to sort of stress that, women who didn't use the ring, look at that, were not protected compared to women who used the ring. It afforded them 92% protection. So, in adolescents, there's lack of evidence, and I don't think anybody is going to do any further studies. But when we look at women, we have to look at a multi-pronged way of looking at them, biomedically, behaviorally, and structurally, and I don't think I need to elaborate on that. To conclude, data on HIV treatment in women is emerging, thank God for that. Treatment should take into account reproductive health. There's new guidelines, and we just need to see how best to maximize its use in women. We need to address some of the gaps. I've already talked about that, and multi-component strategies need to be utilized. Thank you very much.
Thank you, Dr. Dhar. So we do have a couple of minutes if there are any questions for any of our 3 speakers. And perhaps if the